Okay, I think we should get started. I would like to plug some of our presenters today. I'd like to just say that we, of course, have books outside. That a wonderful reach around for an instant reference is Dr. Gabbard's text of Psychodynamic Psychiatry, which is now in the 4th edition. Has an excellent chapter on the clusters of personality disorders and treatments relating to those. If you haven't discovered this book, I would heartily recommend it. It's a textbook of personality disorders by Dr. Oldham. And Chapter 12 is a chapter written by Dr. Bateman in part. And this is a touchstone chapter, as far as I'm concerned, as far as understanding attachment theories and mentalization-oriented model of treatment in borderline personality disorder. Let me introduce Dr. Bateman. He is a consultant psychiatrist and psychotherapist. He is an honorary senior lecturer at the University College London and Royal Free Medical Schools, Barnet, Enfield, and Haringey Mental Health NHS Trust and St. Anne's Hospital. He is a consultant for the Menninger Clinic at Baylor College of Medicine in Houston, Texas, and a clinical tutor at Barnet, Enfield, and Haringey Mental Health Care Trust. He has developed and manualized an innovative treatment for personality disorder, which he will speak about in a minute. He has trained nurses and other allied professionals in its implementation. He's subjected the treatment to clinical trials. He conducted the first randomized controlled trial of day treatment for personality disorder in the UK, and is now uncovering the effective elements of treatment and is subjecting those to further trials. He is, as I said before, he's an international figure in the field. We are blessed to have him here, and I hope you'll give him a very warm welcome.
Thank you very much. We feel jointly blessed then, because I don't have a problem being here. It's very nice. Perry Hoffman I can hardly ever say no to when she asks me to do things, because she's always so charming about it. So, and Jim Dale and Dan Dale, who I've met before at NEA conference, thank you for inviting me, and Trish, wherever you are, I can't see you, for also inviting me. So thank you very much. I'm a firm supporter of the NEA.BPD, and I actually highly recommend them to everybody in the UK and say, why haven't we got something like this? Because you've done such valuable work. So thank you for inviting me. That's why I'm here. Okay. Now I'm going to talk a little bit about our treatment, but I'm going to talk about it from a broader perspective than just the treatment itself, to give you an idea of what it is, what we're talking about here in terms of mentalizing, because it's a fairly broad concept. It's not a new concept, as I'll tell you. It's a very old concept. We've just modernized it or twisted it a little bit, but it's in the literature, and it goes back a long way. It goes back well before the 1960s as a term. But the concept that we're trying to get hold of by using the term is a very old one, as you'll see. Okay, so how do we understand borderline personality disorder? This seems to be a big question. I put here borderline behavior. That sounds awful. But most of what we do is actually look at people and monitor and observe their behavior and then make a sort of diagnosis. Right? When actually what we've got to be doing most of the time is trying to understand their mental processes, not simply their behavioral processes, which is what I'm going to focus on. So what's the best thing to do? Well, why don't we just say it's all the genes and we'll all knock off and go home? Okay. There's a tendency to do this at the present time, and there has been, but as we've heard from Glenn and from John this morning, that it's a much more complex interactional process going on, and I'm going to highlight some of that process. Okay, so what is mentalizing? Well, in essence, what mentalizing is the capacity of each of us to understand our own motivations and the motivations of others according to mental states. Right? So we understand why we're doing something, or why someone else appears to be doing something, saying what they're saying, behaving as they're behaving, according to our understanding of their mind. That's what we do. We gauge what's going on in their mind. And we do exactly the same for ourselves. We work out what's going on in our minds, right? And sometimes we do something and say, what on earth did I do that for? And we think, I don't know. It doesn't matter. And we forget about it. But actually, if we really push ourselves, why on earth? Why did I do that? What was I doing? We try to gauge what was going on in our heads at the time. What were we thinking about? What were we feeling? What were we imagining? And so on. We begin to monitor all aspects of our mental states. But in order to do that, certain things have got to happen. We've got to understand, for example, that my mind is actually a separate mind from your mind. You don't think what I think, necessarily. I mean, I wish everybody thought what I thought, but they don't. I mean, and that's a bit of the trouble in life. You think, why don't they agree with me? Agree with me. You know, we start pushing people and coercing them in all sorts of ways. Right? Gently very often, but we do it. But we have to understand that what goes on in my mind isn't necessarily the same as what goes on in your mind. Okay? We've got two different minds. And this is harder than we think, okay, at some times. And that those different minds hold different mental models of the same reality. All right? Have you ever had that argument yet? You said, and then you say what someone said, and they say, no, I did not. And I say, well, actually, if I got my tape recorder, I'd prove that's what I said. Well, you didn't say, you see. And we all have a different experience. Right? Now, this is absolutely essential for understanding what goes on between people all the time, particularly in interpersonal interactions. Okay? Now, if I'm going to understand what's going on in someone else's mind, I've got to be able to represent their mind in my mind. Sorry, it gets a bit complicated about whose mind we're talking about, but in fact that's what we all have to do. If I say something to someone, they have to represent what's going on in my mind in their mind in order to try and work out what I'm talking about. Okay? And as you can probably guess by now, there's lots of things that can go wrong in this process. Okay? In everyday life, let alone when we've got some other difficulties going on. Okay? So this is what mentalizing is. We've got to hold mental models of the other's mind at the same time as we hold a model of our own mind. All right? And we keep those together. All right? Now, this morning we mentioned group therapy. Group therapy for patients with borderline personality disorder is really difficult. Now, one reason it's really difficult is because when you sit in a room with 6 people in a circle, there's an awful lot of minds going on there. And to represent those minds in your mind can be quite difficult. And it can be quite difficult for even people who consider themselves relatively normal, i.e. not having a borderline personality. You sit in a group and your mind goes a bit fuzzy quite quickly. Okay? So it's a very difficult environment, which is a problem for borderline personality disorder and its treatment, but I'll come back to that. Okay? So, mentalizing is this processing that we're doing all the time, where we're able to predict and justify our own actions and each other's. Okay? That's fundamentally what it is. Now, there's some cognitive abilities that are a requirement to do this. I mean, there's one disorder, of course, known in psychiatry, which very specifically does not have the cognitive prerequisites to mentalize others or even their own mental states. And, of course, that's autism. There's no switch from the internal monitoring of the self-mental state to the monitoring of the other. It doesn't occur developmentally. Right. And that's in autism. But this is a cognitive phenomenon. Now, mentalizing isn't just cognitive. Mentalizing is very clearly emotional, affective, intersubjective in its sort of processing. Right? So it requires an imaginative capacity. Okay? To imagine what's going on in someone's mind. If she says that, where does that come from? I mean, you don't do this overtly like I'm doing it, but you're doing it all the time. Right? And sometimes the only way you can explain it to yourself of why someone's done or said something is because they've got a false belief. Right? If somebody arrives now, if I have a little paranoid moment and say, well, they weren't interested in hearing me, all right, I'll pick on them or do something nasty, couldn't I? But actually, I could also say, well, if they arrived late, maybe they thought we started at 1:15. You know, I could infer that they had an altered mental state, altered belief, and so on, all right? But it requires me to be able to do that, right? Now, I'm going to be telling you, of course, that patients with borderline personality disorder have difficulties in these areas, all right? So if you arrive late, they just say, well, you didn't want to see me, you weren't here, all right? There's not an alternative phenomenon going on very easily, all right? Okay, so because they find these things very difficult. So you have to be able to hold an understanding that people can have false beliefs. And this is quite difficult. This only occurs developmentally a little bit later, you know, around the age of 3 to 4 and so on, this beginning to understand these things, all right? And we have to be able to actually look at visible behavioral cues, but translate those into mental states. Okay? She's behaved like this because of this state of mind. Right? Now this is quite important because a behavioral treatment like DBT, for example, will mostly, understandably, and I'll come back to it later, function on engaging with the behaviors. Whereas from a mentalizing perspective, we need to engage with the mental processes. Right? So you've got a slightly different aim within the system because of the understanding of it. Okay? Now this all gets quite complicated. There's books of what I've just summarized in 5 minutes. There are books on this, and there's another book coming out which is about that thick on this, all right, on all the aspects of mentalizing, because I'm not going to go through it at all, but as long as you've got the idea of what it is, you'll be able to read about it and begin to understand, hopefully, some of it. Now you might argue, understandably, that some of it's questionable. I think that's absolutely right. Okay, it's an idea and concept about mental functioning that needs much further development, and I will come back to that. But fundamentally, remember, for mentalizing, there's a self, right? There's an other, there's a cognitive element, there's an affective element, but there's also an implicit element and an explicit element. Sometimes we try to do it explicitly. We say to people, what are you talking about? You know, we say, well, what are you talking about? I don't understand. And they tell us a little bit more, and they say, oh, I understand. Now that's proper mentalizing. We do it explicitly and try and get in. That's what you're going to do in treatment to some extent. Okay? Most of the time, though, we do it implicitly. We just wander around and interact with people, and actually we spend our time moving between thinking we know what they're talking about, what they're meaning, why they're saying, what their motives are, and so on. All right? And we work them out as we go along. But we don't think about it all the time. We do it automatically. Okay? Now, the problem for therapists is, because I'm going to talk about therapists, is that the problem for therapists is that therapists are not normal human beings, and they won't behave normally. And the idea for therapy and mentalizing is you want your therapist to behave normally, and it's quite hard actually to get them to do so, you see. So we tell them that all you've got to do is remember that your job is to understand what's going on in the mind of your patient. That's your job, okay? The therapist says, oh yeah, I know, but then I get caught up because they're so horrible to me. I suddenly say something like, well, that's not very nice. And that's obviously not understanding what's in the mind of the patient, it's just stating your point of view. You know, something happens in the therapy. Right? I say, look, then you need to remember certain things. And we've come up with various aide-de-memoirs for our therapists as they sit down. Is what's your job? Well, the one I like is understanding misunderstanding. Most things about therapy are actually working out what's gone wrong or happening in misunderstandings. Okay? Patient self-harms, something like that. Therapist says, We talked about it last week. We did so much work on it. It seems to me that actually you self-harmed as a way of attacking me or something. I don't know what they're saying, but something like that. Patient says, what are you talking about? Are you crazy? Therapist says, well, maybe you're angry with me. Oh, goes the patient. Now, we've got videos of these things going on. I mean, less extreme than I've just given. But having to work then on that, what is it I've misunderstood then? I thought maybe you were pretty fed up with therapy or something, and you're saying you're not. And then you do some work on it. Okay? So most therapy for borderline personality disorder is trying to understand misunderstandings that are going on, either out there or in here, in the therapy itself. Okay. And I will come back to that, because misunderstandings are abound. Okay. So what does mentalizing look like? The important thing about mentalizing for therapists to remember is that actually mind states are opaque. You can't know them. Now, I told you therapists are not normal, because therapists always think they do know. Therapists not knowing is quite difficult, right? Now, I say that quite seriously. It sounds amusing, but it's quite serious, because knowing someone else's mental state can cause lots and lots of trouble in therapy. Even being an expert, we think, can cause trouble. Now, this is difficult because some treatments rely on the therapist being an expert in whatever it is. I know about borderline personality disorder, this is what we're doing. I know about self-harm, this is what I want you to do. I want you to work on this over the next week. Okay, these are expert positions. We're not sure they're that as valuable as therapists think, because actually you can never really know someone's underlying mental state. Okay, and you must remember that as a therapist. And what we do is make inferences about them. We kind of work them out by looking at visible cues, looking at eye cues, looking at facial expression, looking at sounds, and basing it on our knowledge and so on. We sort of work them out. Okay? But the problem with inferences is they go wrong. We make errors. Right? And you have to accept that you will make quite a lot of errors in your treatments with patients with borderline personality disorder. So we, in fact, have an overarching principle that whenever you sit down with a patient with borderline personality disorder and your primary task is to stimulate a mentalizing process, then your task as a therapist is to take an inquisitive or not knowing stance. All right? I don't know what's going on. And particularly, I don't know what's going on in your mind. I have no idea until you begin to let me know. All right? It's a great position to be in. So the patient comes to me, and this happens to me a bit more frequently when your name's a little better known. They sit there and they say something like, okay, I've had 3 or 4 sessions. You've not said anything yet that actually has particularly been illuminating. I said, that must be a bit disappointing. He says, I came here to see this big professor, and this is it. Okay? Now, if you want an inquisitive stance, of course, that's fine. I don't care, really. I said, well, yeah, I know. It's pretty awful, isn't it? You come to see someone, you hope he's going to give you something, as far as I can tell, and actually, I've got nothing new to say at all. Is that what we're talking about? I mean, that's awful. Tell me what it's like to have to come and see this big professor who's a dork. Because you're trying to take what their current state is, all right? Not anything else at that particular moment. Okay? So you're taking an inquisitive stance. And the reason you do is that actually the whole idea of mentalizing is that minds can change minds. So if I understand more about your mind, and actually you can understand a little bit more about what's going on in my mind, and we change each other's minds, then we can be delighted by that, if you see what I mean. All right? It's really interesting. Now I understand you a little bit better. Now I can see why X. You see what I mean? This is what human interaction's about. And this is what you're trying to set up and develop with a patient with borderline personality disorder. Now I'm beginning to see how it is that actually you had to walk out. I couldn't work it out. but now I'm beginning to see. All right? And this is terribly important for the mentalizing thing, for a mentalizing process, because being misunderstood when you wish to be understood, or you're trying to explain yourself, is actually an aversive experience. All right? And you've got two choices if you think about it. If somebody misunderstands you, you try again, and then you're nice about it, and you say, well, no, it's not that. And if you're patient, you can keep going for quite a long time. But if you've got one of those slightly impulsive, temperamental characteristics that John was talking about, you think, oh, I give up, and you walk off. You're just too stupid, and you leave. All right? So actually what you're trying to do all the time is actually help someone, help you understand them as a therapist. That's your job. All right? And as long as you keep them on track, that you are trying to understand what's going on in their mind, what their experience is at the moment, you will keep your patient moving along and feeling you're interested in them, you are trying to focus on them, and so on. All right? Now, I should tell you that this is a very tiring task for patients and therapists. All right? If you sit there and you really try to understand what's going on in someone's mind for 50 minutes, everyone gets exhausted. So we recommend that after you've done it reasonably intensively for 10 minutes or something, you relax a bit, let it float off, and then come back to it, because patients get really tired, okay? As do therapists. But being misunderstood will generate powerful reactions in people. And this is what happens for borderline personality disorder. When they feel misunderstood, they will respond by getting out or by coercive trying to make you understand. Right? So it's a very important thing. Now, do we know that borderline personality disorder patients actually have difficulties in this process? Well, there is an increasing evidence base to show that they do, and that is published over the last 5 years, not just by us, by many, many different groups looking at their capacities to understand their own mental states and others' mental states, all right? And it is clearly diminished, particularly in certain circumstances. Now, you can do this with your patients. This is Simon Baron-Cohen's reading the mind in the eyes test. You know, all you get is a certain sort of look, and you have to decide what's going on behind the eyes, as it were, and you're given various options and so on, and then you say what it is. Now, patients with borderline personality disorder can be reasonable at this, but if they get over-emotional, over-excited, or anxious in some way, something like that, it drops off dramatically. Okay, and you can try it out. But can you do this one? Is this person surprised, sure about something, happy, joking? Sure about something. Definite? This is a diagnostic test. Absolutely right. Yeah. Okay, sure about something. Okay, so you can do these. Patients actually quite like them. They didn't like it when they get wrong. But what happens is they become more and more complex, and they're more difficult for all of us. But the patients with borderline personality disorder do fall off more quickly, okay, than normal. Okay, this one? Friendly, sad, worried, surprised? Friendly. You wouldn't mind meeting her. When I showed this once in Italy, one of the Italians got up and said, I don't think it's any of those. She's beautiful. So that's not the point. Okay, friendly. Okay. Now, the issue is this. For borderline personality disorder, this mentalizing process, being able to read behind things, understand mental states in others, understand therefore the motivations of that person, actually, is enfeebled. They're vulnerable to losing it. They can do it, but they're vulnerable to losing it, and they lose the capacities, if they have it, at a reasonable level. They lose the capacity within the interpersonal, interactional realm, mostly. Okay, that's where it's focused. At other times they can do quite well. Yeah?
So you're saying that the possibility, one possibility maybe you answer this, this person being devious or deceptive?
Yeah, or deceptive and so on. They get much more complex, and then they start getting them wrong altogether. But the crucial part of our theory is that this mentalizing process is actually reduced and lost in particular situations, and they're mostly interpersonal situations, right? Or when they become anxious or aroused or excited in an emotional state. Those are the two key areas that reduce this capacity, right? Now this is important for treatment, okay, because treatment will stimulate arousal to some degree, as you know, and so on. So we need to be careful about it, okay? Now, Stein and others, and Fonnegan, so looked at this actually just in suicidal and self-harming patients, and you can see that it's reduced in this group. Okay, most of these were borderline, but not all. But you can see that even compared with other personality disorders, if there was self-harming and suicide, the capacity to read these facial expression phenomena is reduced in these groups. Okay? All right. Now, so I hope I've given you an idea of what mentalizing is anyway, but there are some key aspects to the development. And we, and along with others, and there's other groups working on this, have demonstrated that the capacity to mentalize as a process actually takes place, its development takes place and is consequent upon the attachment relationship, primarily. Right? It's not a genetically determined phenomenon, although there is a contribution. It's primarily influenced by the attachment relationship with the primary caregiver. Right? Now we then went on to have a look to see what's important about this relationship. Are there some features that are important? And I'm going to show you just one or two that I think are extremely important for treatment. Right? There's many, many others that are important developmentally, but are very important for treatment. One is called congruence. I'll just translate that for simplicity to accuracy. Right? So we're talking now about mother-child interactional process. All right? If the mother is mentalizing the child, are they accurate? Do they get the mind state of the child roughly right? As Peter Fonnegan will tell you, his mother got it right most of the time, and he had the best mother in the world. Looking at him, you'd think, I don't think that's quite right, but nevertheless. The point about it is that mums, caregivers, get it right 70% of the time. It's pretty good. Okay? But the real point is this what their primary aim is? Are they trying to work it out? Making the effort, and so on. Now, I gave an example last night, I'll give it again, of a patient with borderline personality disorder with a child who was in the room with me. There were two children, actually, and the boy, who was about 4, was playing with a toy that was there, and then he started to pull at it, and you could see that if this went on, the break, she just grabbed it off him and said, see, just like his father, he destroys everything. Now that's a non-mentalizing comment and statement, okay? They're pretty clear, aren't they, when they're gross, yeah? There's nothing about the mind state, there's just a descriptor about how bad this little brute is, sort of thing, okay? Now another mum might have said, oh yes, look, I'm just talking to the doctor, isn't it? Oh, it's funny, that little thing, his arm does this. You know, she might do something and then try and do something else and so on. All sorts of complex things may go on, all right, which would be much more mentalizing interactional process. All right? So accuracy important. The second thing is marking, which I'm going to come to. All right? So there's two things we have to do. One is get the mind state correct, accurate, and the other thing we have to mark it. Now marking is very simple in its basic sense, is that what's going on and what I'm representing is your mind state or my mind state. In other words, whose mind state is it? Right? Now, typical example, if I hit suddenly bang a hammer on my, I'm banging a nail on my thumb, I'll go, oh, painful, all right? My mind state's pretty overwhelming at that moment in whatever form it is. You might at the same time go, oh, all right? That will be marked. Anyone watching that will know, even if we haven't seen anything, you'll be able to say he felt the pain, but he didn't. Right? He marked that it's your pain, but I'm actually expressing something about it. Okay, this is marking. Right? Whose emotion is it we're expressing? Right? I'll show it you in a minute. We came across this by actually looking at children being inoculated, and some mums would respond in certain ways, or some caregivers in other ways, all right? And we found that the soothing time differed markedly, depending on the reaction of the mother, okay? So the infant comes in, jabbed, wah! Mum goes, what have you done? What have you done? Oh, God, his arm, you must have put it in the boat, you know, all this sort of thing. You think, kind of, who had the jab here? Is it the mum or is it the child, all right? And it's very, very extreme with some people. And the baby carries on screaming, okay? If the mum marks, the mum does something like, a rather complex reaction, actually. Bang, wah! They do something really quite difficult, which mimics pain, but actually shows they're not in pain. Demonstrates something is being done, and so on the soothing time drops off dramatically. Okay? This is marking. George Gergely, as it were, discovered this. So you've got to do two things. One is get it right and mark it, and that occurs and is correlated with secure attachment. Lack of marking or inaccuracy and so on is correlated much more with the insecure attachment phenomena. Okay? So let's just have a look at it. Okay? You can watch this. This is just the still face test, and mum, baby, looking in a mirror, okay, looking at the camera. They look at each other through the mirror, all right, and they interact. But they can only interact through the mirror. Some of you may know this. Child is a well-known child sort of mother interactional process to study, and basically you ask them to orientate, and then you ask, at a certain point a light goes on, the mother goes still. Okay? I'm just going to show you two very quick ones, if they were. What's the mother going to say? Still face now. Now watch the baby. Starts getting distressed, looks around, starts picking at himself probably in a minute. Holding himself, looking at himself, pulling. Okay? You can't put those on the website, by the way. Please, if you're filming it. You'll have to delete these little bits. That was reasonably marked. You see the mother-baby interaction. I won't test you like I do with the students, say, all right, what's happening there and all that sort of thing. But basically, I hope you'll agree that there's a reasonable mum and baby interactional process. It's fairly reciprocal. It goes back and forth. And you think this mum's interested in this baby and what's going on for the child, actually. All right? And actually that's the case. It's a reasonably secure attachment, and it's well marked, and the mirroring process goes along well. And the recovery is very quick. In fact, it's instant. As soon as she starts interacting, ha ha ha, there you are again, and they're off. Okay? Fantastic. Now watch the next one. Okay, doesn't recover. basically. Spends a lot more time playing with himself and so on, and this is much less marked and much less accurate when you measure it. You can measure this, in fact, but I think it's fairly obvious, I hope it is, that there's a distinction between these two. This is not awful, actually, but of course it's altered for many, many reasons. Mum may be somewhat depressed, for example. She may lack any support. Partner's left. All sorts of things, okay, may be going on, which reduce the capacities of the mother at that time. And the other way round can occur, that with one child, there can be a major disruption in the process, as John pointed out this morning, because of the child's temperamental difficulties or genetic components of temperament, whereas another child, the same mum, much more secure attachment. Okay, so disruptions occur, and then there may be external trauma that can disrupt, and so on. All right, there's many things, but we think this marking and accuracy of things is very important. So we looked at accessibilities and returning back to normal, and with the secure attachment relationships, there's really not an alteration in terms of distress. This is basically a measure of distress, whereas with the insecure, there is considerable distress, but it goes down again fairly quickly. But look at the next one, which is the disorganized attachment system. Now this is where there's chaotic circumstances, the relationship's chaotic, there's no mentalizing, virtually none at all going on within the family system or the care system. And look, in the still phase, the child gets distressed and actually continues. They do not recover. Okay. And this is a highly significant result, and it's been repeated. Now, if you think of yourself as a therapist, psychiatrist, psychologist, doesn't matter, with a patient with borderline personality disorder, once they become distressed, it's very, very difficult for them to get back to normal. They can't do it, okay? They simply can't do it. It's no good saying, well, now you're just putting it on. They cannot return back to the normal level. Very important, okay? For therapy, you basically don't want to move your patient too far up here. And notice I say you don't want to move them, because it's your responsibility mostly to try and ensure you keep them here rather than get them setting off on that trajectory.
In these examples, was the mother told to have a still face?
Oh yeah, it's a formalized test, and it's very clear. Yeah, they have a normal interactional process, and they can do that for any length of time until they feel it's right, and it's a normal standardized test. Yeah, it's a well standardized test. Okay, so to develop the capacity in mentalizing, we think this process has got to go on. It's got to go on over time and take place within the secure attachment relationship. And there's considerable evidence for that now in different ways. So what happens then when we lose mentalizing? Well, when we lose the capacity, and remember I'm saying there's a developmental problem for patients with borderline personality disorder, I'm also now saying that when they grow up, as it were, they have difficulty in retaining this capacity. They've got a vulnerable development of it anyway, and then find it hard to retain, particularly in interpersonal relationships. Okay, any relationship or arousal state. Right? And what happens is it reveals, when you lose mentalizing, other psychological processes. And these have been unfortunately named psychic equivalence, pretend mode, and teleological stance. I'll tell you what those are in a moment, but it's basically those phenomena that we think leads to self-harm, suicide attempts, impulsive acts of violence, and so on. Okay? In other words, self-harm, if we just take that, in borderline personality disorder, is the end point of something. It's a behavior, absolutely, but it's the end point. It's what's gone before that's most important. In other words, they're mentalizing, perhaps, hopefully, reasonably well. Something occurs, they lose the capacity, it falls, so then they're unable to manage their emotional states, manage the situation they're in, and eventually it leads and tumbles down to self-harm. Okay? So your job as a therapist is to go back and find out what was intolerable that they were unable to manage, other than through self-harm. And it's very important. Okay. Well, let me tell you because I took the slides out, but what psychic equivalence is really what people, those of you who are psychiatrists, will know about concrete thinking. Things become very concrete. So when I say to my patient, when I said to her, well, you know, what brought you here today, you know, in my affable sort of way, and she said, well, my mother in the car. Right? And I could say, well, you're just being a little bit of a pain, aren't you? I mean, she may have been. But on the other hand, she may well be working at a reasonably concrete level. All right? She knows I didn't mean that. Okay, but that would be an example of concrete interactional process. But fundamentally for psychic equivalence, the importance is this, is that things that are going on in my mind are how things are understood. And I do not understand other people's minds. Okay? So my mind, what I say is going on, is what's going on. You can say what you like, but I don't believe you. All right? In other words, there's no clear separation of mental states of self and other in psychic equivalence. All right? And you will have had patients who say to you, well, you can say that's all very well, but I know you don't want to see me. And then the therapist says, well, you know, because they're a rather naive therapist, they say, but I do quite like seeing you. Well, you might say that, but I know you don't. All right? And the very little movement on it, you will not be able to reassure your patient that actually your mind state and sense of something is different. Okay? So don't try and do it. If Glenn was here, he'd say that's the slippery slope to boundary violations. You then try to prove that you do like seeing them. Well, just to show, I'll give you another appointment. You know, like you start doing all sorts of things. Do not try and reassure your patients in that sort of way. If you're mentalizing, what do? Patient says, well, I know you don't want to see me. I'd say, well, look, I'm really intrigued by that. I mean, I don't understand where this is coming from that I do or I don't want to see you. I mean, where is it coming from that I definitely don't want to see you? Okay? And you could later put in a little challenge. You could say, well, since you're so clear about it, why am I seeing you then? I mean, that's a bit of a mystery, because I could just stop. Oh, you can't stop. That would be unprofessional. All right? So I said, well, I suppose so, but you've told me I haven't done any good. You know, you could really play out to push them to consider what's going on in your mind. But mostly in psychic equivalence, it will not have much effect. Okay? Teleological stance links with it because they understand things actually from not from outcome. They understand the motivations behind things, not simply from understanding your mental state and teleological function, but from understanding what you actually do. It's not what you say you do, it's what you do. All right? So they look for things in the physical world to explain to them why you're like you are. All right? Are you on time? Are you late? Do you tell them where you're going on holiday? Difficult for therapists. Therapists get all edgy, you know. The patient says, well, where are you going then? And you say, well, you know, therapists get very uncomfortable. All right? So the patient says, you think I'm going to follow you or something? You know, because they don't know what to make of it, all right, because you're responding in a way that's a bit odd. All right? So we train our therapists to respond to these sorts of phenomena because actually they don't care where you're going on holiday, but actually they like to know that they can have some representation of you in very concrete terms about where he is. Right? Now they may react in all sorts of ways later. So you say, well, actually I'm going to a luxury resort in Thailand with a spa and I'm going to have, you know, this. You don't say all that. You know, that's just an attempt to stimulate envy, even if you were. But what you might say is, yeah, we're just going to Thailand. And most patients will just say, oh, have a great time. You know, they won't say anything else. Now they may react in all sorts of other ways later, but actually it defuses it, most things. Right? They want something in the concrete world, okay, in some way. Now that's not quite in the concrete world, but you may at certain times have to do things which show your interest. Mostly in our program, they're through things like, if you say you'll do X, then you do X. All right? So if you do agree that some member of the team will ring them that evening, then that person must ring them that evening. Okay? If you forget, there's real trouble. Because you must always say what you'll do, and only say you'll do things that you know are doable. Right? And I can tell you how many times people say they'll do things for their patients and don't. And it's disastrous with borderline personality disorder. Okay, so I know those sort of phenomena are a bit complex of how we understand them, but we have written about them and how we manage them in treatment. But going back to mentalizing itself, we do think that mentalizing itself is an important process for change, an important process in change in borderline personality disorder, and that all therapies are really engaged in a mentalizing process. We just target it much more specifically. So why do I say that? Well, most therapies are engaged in some sort of interpersonal interaction, all right? And we know that most change doesn't take place through insight, certainly, or emotional expression, actually. It occurs through the joining in of an emotional experience, really, in the context of an attachment interaction. So all therapies, doesn't matter whether it's DBT, behavioral therapy, transference focus, schema focus, set up an interpersonal, interactional process and try to make it a reasonably secure attachment process that you're setting up, i.e. develop some sort of trust. And this is very hard for borderline patients. They find it extremely difficult. Right? So it's actually probably the setting up of that process that's important, much more than the particular techniques you're going to give. Okay? Which is why in the study that Glenn talked about between transference-focused psychotherapy, DBT, supportive therapy, they all did well in most domains. Right? Because they all sit down to try to set up a reasonable therapeutic relationship in which some trust is engendered. Right? Irrespective of what techniques. Okay? Now the problem is this, is that if I'm saying, which I am, that in borderline personality disorders a reduced appreciation of the mind states, then if all therapies are actually sitting down to try and develop something in the interpersonal context, actually they will potentially stimulate a loss of mental functioning for the borderline patient. They're sensitive to interpersonal context, for one thing, and of course if they've got impoverished model of their own mental function and others, it's going to create real trouble, just sitting down having therapy. Okay? So it's this that creates all their vulnerability. If you don't remember this as a therapist, you will find that you can potentially harm your patient. You can do quite a lot of damage, all right, by overstimulating, by being too interactive, all right, by not pulling away when you should pull away, and so on. All right. You will stimulate, in other words, the very pathology of the patient that you're trying to help them with. All right. That pathology of reduced mental states. Okay. Now, so coming back, there is this danger of what therapists may do. They'll overstimulate the patients and therefore reduce the mentalizing capacity and make them less able to participate in treatment, is one thing. Or the other thing is they become an expert. Okay. We know what to do, we know what's going on, and so on. And we start saying things to our patients like, I think what you're really telling me. Now, even at the best of times that's a bit patronizing, but I can assure you that therapists say it quite a lot. The patient talks about something, like they've just been shopping, looking for something, but they never find it. They couldn't find it and they're fed up. And the therapist says, well, I think what you're really talking about is you're looking, and then they say looking, they relink it or do something else with it. All right? This is very dangerous, all right, for borderline personality disorder, because it starts to take over the mind of the patient. If you work it out, if the patient talks about something, you say, well, what you're really talking about is this. Your mind then has primacy over their mind. Okay? You might talk about this, but I know what you're talking about. If you say you're feeling X, I say, well, I know what you're really feeling is angry. All right? And things like that. These are very, very common, in fact, when you watch videos. And they're meant benignly, they're meant helpfully, they're not meant to upset. But for borderline personality disorder, they will cause real problems because your mind state is taking over the mind of the patient. And if your patient cannot really discern their own mental state, what can they do when you tell them what their mental state is? Well, they can do basically two things. One is they accept what you say and agree with it, or the other is they reject it wholesale. Right? That's all they can do. Rejecting it wholesale leaves them at least with a sense of, I can work out my own mind, I don't need you telling me. All right? At least they're trying to do something. Agreeing with it is much more dangerous. Because agreeing with it, they simply take on what you say is in their mind. And they never develop their own ability to discern their own mind states. Okay? I hope that's clear. I'm sort of worrying I'm confusing people a little bit. But fundamentally, the therapist who takes over the mind state and tells the patient what they're thinking, what they're feeling, how to behave, what to do, will undermine the patient's capacity to work it out and develop it themselves. Okay, so you need to remain reasonably in an inquisitive stance. Not neutral, you don't have to be neutral in our view, but you do have to be continually inquisitive. Right? So what do all treatments face? Well, the first thing they face is actually minimizing these harmful effects that may occur. All right? And in order to do that, you need to structure treatment. All the treatments that Glenn talked about are reasonably structured, they're coherent, they have teams, they form contracts, they look at symptoms, they look at behaviors and make a hierarchy of them. There's a huge amount of non-specific therapeutic effects that are going on in these treatments. So we came up with our principle that borderline personality disorder, any treatment is going to be reasonably effective to the extent that it can enhance a patient's mentalizing capacity. And DBT enhances mentalizing capacities. It forms quite a secure attachment relationship. It fosters that through its telephone calls, through the activities of the therapist. And it also tries to help the patient understand why they're doing what they're doing, even though it's targeting behaviors. But at the same time, we must not generate too many iatrogenic effects, okay, if at all possible. Okay. Iatrogenic effects are reduced as long as you don't overstimulate your patient. Don't make them too anxious, don't overexcite them, don't give them too much to think about all at once and all this sort of thing. Okay. And if your treatment's reasonably flexible. Right? You can't be rigid in your treatments of patients with borderline personality disorder. It simply won't work. But you can be flexible across a range of ways of working with them. So will you see them outside the session? Will you talk to them on the phone? You may have to, and you may do that. And it's perfectly okay in our treatment with some flexibility. All right? Because we think that if you do that, change will actually occur through that process, and change occurs when your patient learns something new. They feel that you've learned something new about them, and you've understood them, and your mind's been changed about them. All right? There's nothing worse than thinking, people just see you like this. Right? Once you realize they see you like this, and maybe that, and now you're not so like that, they feel much richer in themselves and much more secure. Okay. So this is where our principles come in. So we put forward an idea that mentalizing was actually one of the things that affects change in borderline personality disorder. You're to move them to a more robust state of capacity to mentalize. So they can mentalize when they're emotionally aroused. They can mentalize when they're in an intimate situation. They can mentalize when they're anxious, and so on, rather than losing it. So that's what we target and what we focus on in the whole of treatment. And I'm finally going to go through just some of that, because I've said in these slides that it's the process that you set up with the patient that's probably the most important thing, and not actually the cherished techniques that we all have. All right, you've got to set that process up. And for us, it has to be one that's clearly a mentalizing process. Why are you like you are as you are, and so on. Right? Why am I being like I am with you at the moment? All right, so I'm going to... Okay. Now, we think, and this is still an empirical question, but it is going to be studied, I hope, that in any treatment, if there's no change in mentalizing, there'll be no improvement. Doesn't matter what the treatment is. Behavior therapy, schema-focused, transference-focused, mentalizing therapy. If there's no shift in mentalizing, there'll be no improvement. And we know in all treatments, only a percentage of patients improve, about half, just over half, for most treatments. Okay? I think in the other group, there's no mentalizing change for whatever reason possible. So what does work? Well, we do know, and I'll jump these because we've done them, but I just want to mention the recent comparative trials, only to say that comments about these are on the NEA.BPD website, in fact, in the scientific section, where some of us have written comments about these comparative trials. I do urge you to look at them, because the results are nothing like as straightforward as all us proponents for each treatment would like to suggest. So it's worth looking at, but they've already been covered. Okay. So finally, just on to treatment itself. The therapist stance, we think, is the most important aspect for mentalizing treatment and for treatment of borderline personality disorder. And it's the therapist stance that we train our therapists in. Now, we don't use therapists, highly trained therapists, for our research trials. We use nurses who we train, okay? And we train them for 3 days, and then they're on their own with some supervision once a week. Okay, with peer group supervision as well. That's how we did the partial hospital treatment program and how we've done our intensive outpatient treatment program, which I will end on shortly. But basically what happens is the therapist's problem is when you sit down with your patient, you will stimulate the attachment system and you'll want to explore, so you will potentially reduce their mentalizing abilities just by sitting with them and starting to explore things. Okay? That will lead to discontinuities of their self-structure. They'll feel anxious. They won't know who they are, why they're there, what they're doing, what you're doing. They'll be uncertain about it. And they will then attempt to structure. And when they attempt to structure, they will start making schemas. They'll start non-mentalizing. Okay? And non-mentalizing is the thing you're going to look for in your sessions. Okay? Non-mentalizing is easy to spot, as you've already realized, when it's fairly gross, but I'll give you another element where you see it's quite easy to spot. A patient some time ago now, 6 months ago, was sent to see me, was working at university as a researcher, in maths, actually, which might explain, to my bigoted view, might explain the problem, really. Anyone who's really good at maths, I'm always suspicious of. But she was brilliant at maths. But they sent her to see me, well, referred her to the psychiatric service, because she was sitting under the desk and had been doing so for 3 months. I think 3 months is quite a long time for an employee to sit under a desk, but in the mathematics department of this particular university, they were very tolerant. But eventually, they said, look, don't you think you better see someone? Because what she was doing was her research and then handing out bits of paper, and they put it on the desk. Anyway, she came to see me, and I said in my normal pleasant way, what's going on or something? And she said, well, nothing really. So I think, well, so I prod and probe a little bit more. Anyway, every time I did something, she'd say something. She'd give an answer for a couple of sentences, and then she'd just go, yeah, well, whatever. Now, I'm not a terribly patient man sometimes, and after about half an hour of 2 sentences and then the response of, and whatever, I started to say, well, what was going on under the desk? And so she said, well, I just felt it was okay. Well, whatever. So, by about the 55th or whatever, I said to her, look, I don't know what this whatever is. What is it? And she said, whatever. Yeah. Now, that's what got me, you see. And I said to her, look, I'm not going to be able to carry on if you keep saying whatever. I said, it's beginning to really, really annoy me. Right? Now, this is not good practice, okay? This is not good practice at all. But this is non-mentalizing. And what was happening was that I was then unable to do anything. I couldn't think. I couldn't, she just kept on blocking off. Now, not deliberately. She just had no idea what to tell me or what to say, okay? So eventually I said, look, this whatever thing looks very important to me. I can see that we're not going to get anywhere with it today, but we're going to have to, because it seems to stop everything. This is non-mentalizing in a very severe way. She couldn't take anything forward at all, okay? And your job as a mentalizing therapist is to maintain your own mentalizing, which can be difficult sometimes, and to stimulate mentalizing in the therapeutic context, okay? So your job there is to try to get her to begin working on this better, right, a little bit more, bit by bit, okay? And to do that, you must take this not knowing stance, which is actually realizing that you and the patient actually only experience the interactions and what's going on impressionistically. You don't know more than your patient. Right. Basically, you know more about borderline personality disorder as a theory, as a diagnosis, but not as an experience, for example. Okay? So fundamentally, you actually are the same level as your patient. It's very, very important. So you will make errors, you'll make misunderstandings, you'll overstimulate your patient, and as long as you take this stance, you will mostly keep it in reasonable control. Right? So we train our therapists, for example, to de-escalate things. And the de-escalation is mostly considered in terms of when a patient gets upset or angry or blows up in a session, which does occur because they misunderstand something or feel misunderstood, is the therapist immediately takes it back and says, well, hang on, what's going on now? What's happened? Have I done something? Was it something I said? You make the patient, instead of focusing on their own experience at that moment, focus on what you may have done to stimulate the experience. Do you see what I mean? You take their mind out, get it to consider something else, and get it back again. Right? And you're responsible for it. It'll de-escalate most situations, that sort of technique. Okay? So you're always trying to understand your own contribution to what's going on in the session. Right? Very important, okay? Because your main aim is to stimulate with your patient lots of different alternative perspectives. Well, I can see how you see it like that. Now, this is a validating technique. Now I'm beginning to understand how you saw it like this, or you experiencing it like that. But actually, it occurs to me this. Place an alternative in there. Right? Now, you will lose the ability to do this after about 5-10 minutes. Okay? You will lose that capacity, I can assure you, when you're sitting with your patient who's got a borderline personality disorder, and your job is then to get it back. Right? And you can get it back in all sorts of ways. So your patients will challenge you. They'll say, well, I don't know what I mean. You're supposed to tell me what's going on. That's why I'm here. All right, or something like that. So you've got to have responses to this. All right? So, so we do these in role plays and we train our therapists, but actually, I'm not here to tell you, I don't know what you should do. That's a perfectly fine response. I have no idea what you should do. I wouldn't know what to do under these circumstances, necessarily. So what are we going to think about it? Let's go on with it. Okay, move it back to the interactional process between the two of you. But all the time, you're trying to actually engender different perspectives within the interpersonal realm. Okay. Is that clear? Are you fairly okay with that? All right. Let me tell you what therapists do, because we did all our research videos. We've got hundreds of them. We supervise each other. What do therapists do when challenged or when they don't know what to do? Patients say, well, you're supposed to be here. You're supposed to tell me what to do. That's why I've come. What do therapists do when they don't know what to do? What do you all do? Any idea what you do? Have you videoed yourself?
What do you mean by that?
Yeah, you ask them a question. You get the patient, you lob it back. That's a non-mentalizing technique. Okay? It's non-mentalizing, it doesn't do anything. It actually will just probably arouse things. All right? So I'll tell you what therapists, they either do that, or the other thing is they go completely silent, and then they go, they nod, which infuriates the patient even more. Okay? Right? So you've got to have other responses. And really what you've got to try to do when you don't know what to do, we ask our therapists to place their state of mind explicitly into the session, as long as it's in the service of fueling and increasing mentalizing. Not just to reveal everything I'm thinking about you at this moment. So you place it in, you say, well, I think it's a very good question. Actually, I don't know what to tell you to do. I don't know what to do. I don't know what to say. Is a much better response. Okay? And then the patient has to work out, why don't you know what to say? You're supposed to be the professor round here, or something. You get some response. So that's fine. At least you've got a response. I say, yeah, I know. But even me as a professor around here don't know what to do. I don't know what to do. But I can think of ways of kind of working out what we might do. Okay? Why don't we just consider a little bit more? Go back and then you move on. Okay? It's much easier to get them to stimulate them in that way. Okay? So this is the key to our treatment. We train our therapists to do this and to do it within many of the common situations: patient threatening self-harm, patient having self-harm, patient threatening suicide, having made a major suicide attempt, patient actually challenging the therapist, patient coming in saying things like, this treatment's useless. I might as well stop. I don't know why I'm coming. All right? It's a very common phenomenon. All right? And they're usually the result of a loss of mentalizing within our view. All right? They don't know how to process what's going on, so they begin to structure and rigidify. They say, this is useless. I should have this. I should have something else. And you have to do the work on that. All right? So we train our therapists to do this. And so you don't, if a patient says, look, this treatment's useless, I've come for 3 months and nothing's changed, okay? The therapist mustn't get defensive. Don't start saying, I thought it was going reasonably well, actually, But therapists do, honestly, after a bit of discussion, they'll say, but, they'll try and be a bit more positive, understandably. Right? These, again, are non-mentalizing phenomena. They're not making the patient understand where their insistence is they need to leave. Is it justifiable? If it's justifiable, then you should leave. No doubt about it. You wouldn't stay in a treatment that was really not helpful. But you have to work out that it's definitely not helpful before you act. Okay? So never try and keep your patient there. Persuade them to stay, I mean. Spend your time saying, well, okay, maybe it's wrong. Let's just think about this. Where's this come from? Why now? I don't understand. Do you see what I'm getting at? And then you can move through the process, and they may then decide to leave, of course. Okay? So that's the process. Now, the problem with all this is that this is our treatment program, and we've tried to look at it very, very carefully. Because I'm a proponent of research in clinical practice. You have to make sure that what you're doing actually has a reasonable effect and look at outcomes and so on. And this all got muddied, I'm going to do this fairly quickly because I want to finish and leave a little time for questions, by Mary Zanarini, the CLIP study, and all these longitudinal studies, follow-along studies, because they said our patients were getting better anyway. Okay, which is a big problem. Now we think this research is a problem in a sense because it's probably to do with sampling and the groups that they've got, which are different from the ones that often we seem to have in treatment. But nevertheless, there is definitely an improvement of patients over time, and there's no doubt about that. But the things that don't do so well are actually the problems with social interpersonal function. That's already been mentioned this morning. Okay. Now we hoped that mentalizing, which focuses so much on the interpersonal understanding, how I understand myself, my relationship with you, your mental states, your emotional states in relation to me, and so on, might have a better chance of helping social interpersonal interactional process. Okay. So we've looked at this carefully, and we've followed up all the patients we originally randomized in our original randomized study. All right, in the 90s, and we followed them all up, and we found nearly all of them, in fact, and we interviewed them, and we also did a structured review of the notes that we had and everything. And I won't go through it in detail. One patient, in fact, in the control group had died from suicide, but that was the only suicide in the whole group. And we looked at global assessment of function and various other outcome measures like length of hospitalization. Now this is 8 years after they were originally first seen, right? So they were seen, they had 18 months treatment, they had 18 months step down sort of outpatient follow-up, and then the treatment was stopped. So it's 5 years after all treatment was completed, right? And what we found was, along with Mary Zanarini's and the CLIP study, that most of them don't meet criteria for borderline personality disorder. The criteria, the number who meet criteria has dropped dramatically in both groups, but for the mentalizing group, it's a much lower number who meet criteria than the treatment as usual. So loss of criteria, if that was an improvement, is better in the mentalizing group. For the global assessment of functioning, which looks at a wider function of the individual, you can see in the mentalizing group is still as a mean below 60. It's 58. It's relatively low in my view, although people think this is not bad level, but in the treatment as usual it's lower. There are in fact more patients in the mentalized treated group above 60, which is a reasonable step in the global assessment of function. For those of you who know, you're doing a lot better when you're over 60 on the measure than you are when you're beneath it. So there is some suggestion that the social interpersonal function is better, and that just represents it over time. You can see the treatment as usual getting better, the mentalized group getting better, and there is a significant difference, albeit still below 60 for both groups. But we found the percentage making suicide attempts drops off dramatically. It dropped in treatment and it stayed very low in the mentalizing group. This is one suicide overdose, I think, in the treated patients. So once it's gone, it's basically gone. Certainly use of A&E also follows that and mirrors that, and the mentalizing group are doing better than the treatment as usual. As up they are in the group that are going to hospital. They're hardly going to hospital at all. And in fact, this is one patient, I think, who went in for a short period of time. So generally speaking, in the partial hospital mentalizing program, over a period of 8 years, these patients are doing better than if they'd been in the normal services, okay, on most measures, in fact, all measures, basically. Okay. So there is an effect. Right. Now we then developed a program which is just outpatient mentalizing. In outpatient mentalizing you have an individual session and a group session. Now this is where we join group with individual. And I should tell you that this has led us to see, we've videoed many of our individual sessions, we've audio recorded everything so we can rate the therapists and so on, and it's fascinating what we say with our patients and so on. I'm a little bit more scurrilous, it turns out, than my other therapists. I'm more mischievous in sessions, for example, and do things, but that might be because I'm more experienced or just because I'm slightly antisocial borderline in my attitude or something. But, you know, I have a little bit of a go with some patients sometimes. And as one of my patients said to me the other day, she came back to a session and she said, I do want to say something to you. She said, I think I can probably say it now. I've been thinking for quite a long time. She said, but, you know, when you say some things, she said, you don't half pack a punch sometimes. Okay. So what did I do? Because I'm a mentalizing therapist. I thought it was probably true. I didn't doubt it. I said, well, you know, tell me what is it that made you realize that? What packed a punch recently then? Tell me a bit more about it. Where is it? Where was it coming from? And so on. And we went over that and found out. And I eventually could say, yeah, look, I can see that. And actually, it wasn't slightly sort of hurtful, I think, what I said to you in that way or something. And, you know, and then we could work a bit on that. So we could establish what was hers and what was mine. It was clearly marked, this was me, not you, not your misinterpretation, and so on. So we do this sort of thing. One of the other ones that my colleagues liked is on a video, I'm on the video, which I can't show you because the patient won't allow it, but the patient was sitting there and she suddenly says to me, you're not listening, are you? Right? This is all on video, so I'm sitting there, you know, like this, looking sort of thoughtful or something, and she says, you're not listening. Now, I didn't know momentarily whether I was or I wasn't, because I mean, sometimes we are, sometimes we're not. So I just said, well, actually, I have no idea what suddenly made you say that, because I didn't. I had no idea. She said, well, you just looked out of the window. Now, I suddenly realized that was correct. All right? Now, what am I going to do with this? Well, as it turns out on this video, what I say was completely out of my sort of unconscious, pre-conscious, as it were. I said, play it back. We went back, and there I go like this. I'm sitting looking at her, sort of seemingly listening, and then I look, there's a long window in my office, and I just sort of look out, my eyes move, and you could see I look out, and then she says, you're not listening. All right? So I look at her, and I actually say quite something, I said, look, I know I'm a man, but actually I can multitask. My eyes can move, and I can think at the same time. And she looked at me, and she said, I've got nothing to say to that. Now, what I'd done, all right, was okay, because in fact, she's a patient who easily gets worked up. She easily gets aroused, and it was about to start. Now, I obviously had picked up that. I wasn't aware that I was particularly conscious of it. And what I did, twisted it so it left it. Okay, so it was a reasonable intervention, we decided, even albeit a bit mischievous. But we learned a lot about ourselves doing this. And this is the study, and then I'll finish, is that we've randomized, this is an intensive outpatient, we've randomized 138 patients, I think it is. Well, it's more than that, I'll show you the diagram in a minute. But actually, there's 70 and 58 in the groups, and they're contrasted with supportive clinical management, which is the best we could do, which has got proper therapy time, it's got individual therapy, supportive, with group, operationalized, highly advocate-led, and very supportive and problem-orientated. Okay, it doesn't really matter. So we had 168, we've ended up with 70 in one group and 58 in another. We lost some on the way in the randomization. But just let me give you two quick results. We haven't got all the data. But one is that suicide attempts have clearly dropped off in both groups. Okay? But there is a difference between the mentalizing group and the control group. And the MBT group dropped much more quickly and significantly more quickly. And you can see that on this, the suicide attempts go down in both, but the decline and rate of decline is much quicker in the MBT group. So for serious behaviours, we're clearly having the effect. Now, we haven't got all the other data. This trial is now complete. It was supported by the Borderline Personality Disorder Research Foundation, and we hope to submit it soon. So I'm going to stop. So just to summarise, mentalizing, understanding your own mental states, your own motivations according to your mental states, and understanding them of others is actually a normal, everyday phenomenon. The capacity to do this is reduced in borderline personality disorder, and it's particularly reduced in relationships, interpersonal situations, or when emotions are aroused. The mentalizing capacity is therefore reduced. It's probably reduced. We now know that the prefrontal cortex is the area which is important for mentalizing, and actually the activity there is reduced in borderline personality disorder. Particularly, it becomes overwhelmed by the emotional states in relation to the amygdala that Glenn talked about, and then the behaviors will be revealed. And the behaviors are an attempt to survive. We're talking here not about manipulation. We're not talking about getting at anyone. We're not talking about aggression, in my view. We're talking about survival. How do I help my mind survive, help myself survive? And then I do this, and actually I feel I've survived. Okay? And this is what we're talking about. So your job is to help the patient maintain mentalizing over time in these complex situations, and that's what your task as a therapist actually is. So thank you very much for listening to me for rather too long.
For a 10-minute period. Go ahead and raise your hand if you have questions.
What is the frequency of your visit?
Sorry, could you?
How often do you see the patient for this approach?
Well, in the outpatient, it's once a week for individual therapy and one group session per week in the outpatients. In the partial hospital, it's much more intensive. What does? Treatment as usual. Treatment as usual. Sorry, yeah, treatment as usual is TAU. Yeah, someone over there first.
I had a question. You said don't try not to get the patient around too affected. I had a patient come in that was crying when she got there.
Yeah.
And what if we never got to a new point and she was, well, we had moments, but then she was crying again after feeling a little bit better. She was crying again with reception when she left.
Yes.
So, what do you think?
Well, no, it's really hard because, of course, some patients arrive in a particular emotional state. But as a mentalizing therapist, your job is to then, which is probably what you did, is simply to try to understand what their emotional state is. Now, because they're tearful, it's not necessarily that they're miserable. Do you see what I mean? We'll start guessing. Don't guess. Get them to try to say, we'll say, oh dear, what's going on? Keep yourself reasonably neutral. Now, they may or may not, I don't know what your patient would say to that.
She said that they haven't called a name, and so she thought she missed her appointment. I said, well, I'm seeing you now, and it just never...
But that was, you see, where you've gone non-mentalizing. Excellent.
Okay.
You see, you say, the patient says, oh, but they didn't call me. I thought I'd missed the appointment. Okay? And you say, but I'm seeing you now. It won't reassure her. Okay? She's already actually in a state of mind where her experience is that she had missed her appointment.
Right.
Yeah. No, it doesn't make any sense to you. But you have to get it to begin to make sense to you. That's what the mentalizing therapist has. You have to say, oh dear, what was going on then? You know, what happened? And get them to describe how awful it was. You know, they suddenly thought, nobody's going to see me. And that's devastating. All right? And that is awful. Okay? And they haven't been able to manage that emotional state. You can't reassure them. Just that we're having our appointment now. Okay? And you may have to spend the whole session on that particular... Oh, well, she was quite interesting because it was a really, really difficult assessment, actually, because of what she was doing. And then she engendered enormous sort of problems in me for counter-transferentially, where it was very much like I was going to feel like headbutting her or something, so that, you know, because it was so sort of elevated, you know. So in the end, I don't think I actually got round it. I actually said, you know, I'm only going to come back to this, I'm going to come back to this whatever, but not now. All right, you can say it as much as you like. I kind of diffused it and said, so as much as you like, but I still want to know what it is you keep cutting off by saying whatever. So I just tried to identify it, to be honest, and didn't get any further. Yeah.
Well, I've got an analyze myself here. See if I misunderstood it. The reflection of feelings and sometimes counterproductive, borderline continually angry. They could take that and really become angry because I said that. I mean, you're saying, just dig a little deeper. Why are you really upset? What's going on?
Yeah, you don't want to, you can identify emotional states. I mean, clearly your patient's upset. I mean, just in an ordinary generic way. All right? But you need to get them to start expanding that, what upset is. Okay? What's it like? You know? Or even, what's it like now you're seeing me? You know, it's almost like it's no good now. Do you see what I mean? Yeah, it's ruined. But it has been ruined because actually she's overtaken by the terror that it wasn't going to happen. And that's what you're going to... So it's spoiled it. Right? So you really want to get them to keep doing... Don't keep telling them that they felt so hurt that, you know, that that's why they're now so upset. Do you just kind of follow the idea? Yeah.
As a parent, I mean, I'm obviously not trained as you all are trained, and how can you give us some ideas, or do these ideas still help the parents? Do we act the same way, try to help them minimize?
If you're a mum, just be a mum, please. Don't spend your time trying to work out if you're mentalizing. You will be anyway. But in terms of those mums and or parents who really have that difficulty, then there are research studies going on at the moment of trying to put in mentalizing training. There's Minding the Baby study in New York, for example, where they're trying to help the mothers understand the minds of their babies and so on, and see what effect that has on developmental processes and so on. And Arietta Slade's doing that and so on. We all fail to mentalize our children, don't worry, and they're pretty good at disrupting our mentalizing. And when they get to adolescence, you can't even think about them at all. You think, oh God, I wish they weren't, or something like that, don't you? It can get really difficult at times, all right? And mums get nervous of their sort of brutal daughter who seems to, and things like that, because they disrupt our processes very quickly within the emotional states. It'll happen. Just make sure you retrieve it as quickly as you can when you lose it. You'll lose it with your children, don't worry. Okay.
I've been trying to imagine what a conversation between you and Dr. Kernberg would be like.
Oh.
I know you all that opportunity.
We have had that opportunity, yeah.
But he would use terms like self-object differentiation, object constancy, those kinds of terms. Are you saying something different, or are you explaining it in a different way?
Yeah, it's a very interesting question, because we don't use those terms because the theoretical view is not based on object relations in the sense of Otto Kernberg's view about object relations. It's based within the attachment process and actually understanding states of mind rather than specific object relationships. So we have a different terminology. Now, whether you think in the end we're talking about something very different, I doubt that it's massively different at all. But I do think it probably makes a difference in terms of treatment process, which is where he and I have firm discussions, should I call them, about the treatment process. Okay. No, sorry. Yeah.
I have an associated question. Let's say you had a conversation with Tova. How would you differentiate your approach differently from him, from his approach of mirroring?
Well, I think, that's, again, a very different... We have discussed this in our book, actually, these sort of differences and distinctions, because we don't claim to have discovered something particularly new. We've just sort of operationalized something, and it takes components that can be seen as cohesion, particular. I think one difference is, perhaps, that we are very... clear about the therapist not necessarily being used as a self-object, but actually represents something of their own state, their own mind, and so on. Now, I don't know whether that's a major distinction, because I'm not a cohesion therapist, but Sigmund Cartwright is a cohesion therapist, and he thinks that the stance of the therapist is very different in mentalizing from his stance as a psychologist therapist. So, the stance appears to be quite different, and I think it's the position that you place yourself in relation to the patient that's probably different in clinical practice. But, go back to Glenn's point, or John's point, therapies overlap massively. The way therapists behave overlap massively, irrespective of their approach and theory. We ought to stop.